This is a case of carcinoma tongue where we had done partial, almost bordering hemiglossectomy in such a way that we took a flap to make sure that the snake tongue is avoided. You can see the tongue looks normal, absolutely as it should, and no flap was used. We managed it by using matridum, but actually more than that, by positioning the incision and flap in such a way that it can project well, speech is not affected. Jeep bhar karega. See, there is a mild deviation to this side, which is because we have taken out that part of tongue, and along with that the nerve supply also goes away. Now the projection of the, this wheelbarrow phenomenon that you know. What is the cause for this wheelbarrow phenomenon? Wheelbarrow phenomenon is when you ask a patient to projecting the tongue, it moves to the same side if there is a hypoglossal nerve injury. 12th nerve. Now, I thought you would know it because the question was, why does it happen? Now, the second question becomes irrelevant now. All facial palsy, frontal, whichever palsy, the organ moves towards the healthier side. But in this case, it moves towards the affected side. And the reason is what you see in a wheelbarrow. Wheelbarrow is a typical thela, or the one which is used for the barrow, which is used for grass. So if the wheel breaks, it falls to the same side. That's why the term wheelbarrow phenomenon. And why does it happen? Because genioglossus is responsible for projection. Genioglossus is a fan-shaped muscle. So it kind of is narrow here and it broadens like a fan. So if this side is affected, in projection it will move automatically to this side. Now what has happened in this case, it is not the nerve which is affected, it's the muscle itself which we have removed. So this side is weaker than the other side. So when he will project, the genioglossus of the left side is the one which is working. So the right is not working. So the wheelbarrow phenomenon happens. It drops to the right side. That is what I was trying to tell you. Bring your, come closer. Now you can see that it is healed well and there are no patches because you're not a tobacco chewer. The previous patient was a tobacco chewer. So you saw field cancerization in that case. There was a palate, second primary at the palate. Second primary is the one that happened 6 months after the first one. That patient has received treatment 2 years ago and developed one at the palate now. That is because we have treated one side, but the tobacco has affected all sides. In his case, it's all clear. That's why I was keen that he gets everything done because he's cured of his cancer. So he should never have it again. That is what I was wanting. With the tobacco chewers, there is field cancerization. You see the mouth is absolutely clean. You don't see any melanoplakic, leukoplakic patches. So the possibility that he developed the lesion was related to either his tongue, his teeth, or the other possibility is HPV. He's never smoked in his life. He's never chewed tobacco. And that's the incision again for the neck dissection which we have started using. And the monocrill never disappears, they claim, but it doesn't. So it's here. It's how many days post-op now?
Surgery was on May 18th.
May 18th he was operated. So it's already, we're recording it. I hope you don't mind. We'll not take the face. No, we'll not take your face. Don't worry. Even if you do, we'll be just putting a good face on the screen. So there's no reason to worry. Bring it closer. So we can see that there are no neck nodes. This is a drain side. So we are good as of now. So I'm pleading with him to go for radiation. The plan, based on what was the logic for radiation?
The DOI being 0.7.
So the cutoff idea used to be 7. Now they brought it down to 5, like they've done it for obesity. But I think that 5 comes with LVI and other factors. So LVI, there is no such thing as LVI. The only factor that he has is DOI, a node negative case. So the good risk patient who should do well regardless. But I'm still advising him to go for adjuvant radiation. It is just that it will lead to a little bit of sore tongue, buccal mucosa. See, this is what I was trying to tell you. Counseling in consent taking is not about making a hernia also look like a deadly disease, which is what somebody does on paper. Ticked, I have informed. That's not what you do. You you encourage the patient into going for a therapy if you think it is going to benefit the patient. And that that lady who comes post radiation, tongue case only, Biswas, Jyotirmay Biswas's relative, my own student's relative. She took it, she's fine through it. And she, of course, had predisposing conditions. But I told her the same thing. I said, counseling, I'll do. So now he's already got that thought in his mind. I'll still give him 48 hours to think. Okay.